Okay, so we're still talking about pain relief and part of a post-op protocol. What's very common to use as a group of the non-steroidal anti-inflammatories known as the NSAIDs. And most of these are part of a standard protocol. I would say these are all in that category, except that we don't typically use aspirin. The one thing I will say about aspirin is, and I've always told you, when you take a history, there's a lot of owners, there was a big kick for a while that people should take an aspirin a day kind of as a blood thinner, as a cardiovascular protectant. And sometimes people just assume if it's good for me, it's good for my pets. And they'll do the same thing. And they don't always tell you in the history. So you always check about that, because basically aspirin makes the platelets less sticky. And if they're coming in for surgery, aspirin doesn't interfere with anesthesia, but aspirin is going to interfere with clotting. So if it's a surgical procedure and there's going to be bleeding, sometimes we will, if it's not an emergency, we'll postpone. We'll take the animal off aspirin maybe for a week. The other thing is, you don't want to send home these other prescription NSAIDs if they're giving aspirin, because if you give them together, they can cause some of the side effects we're going to talk about. So it's very important to make sure. And acetaminophen is known as Tylenol. And again, sometimes it's a part of over-the-counter cough suppressants, but not, okay, I don't know where it is. Sometimes, we want to make sure they're not taking that either. They really shouldn't be taking Tylenol. So carprofen is Rimadyl, and meloxicam is Metacam. I'm going to put these in an email on a list. Ketoprofen is known as Ketafin, and I want to say Diroxicib is Diramax, and those are the most common ones to know. So carprofen, Rimadyl, meloxicam, Metacam, which Metacam is a liquid, and it comes in 2 concentrations. It's used a lot for smaller patients. It's used for exotics. So I wouldn't say, we do use it sometimes in dogs, but probably the 2 most common that we use in dogs is the Diramax and Rimadyl. Those are the trade names. Ketafin can be used via injection. And I want to say Rebenoxicib is Onsior, but I have to double check that. So you guys in surgery, a lot of the dogs after induction get an injection of Rimadyl. Carprofen comes in like chewable tablets, regular tablets, and then it has an injectable form. And that injectable gives them 24 hours. So on top of their pre-meds, they're going to get butorphanol, they'll get Rimadyl, and then usually the next day after surgery, 24 hours, you'll put them on an oral tablet of Rimadyl or carprofen typically. And there's always notes underneath here. They do have some antipyretic properties, and antipyretic is anti-fever. So they can be fever reducing, although if it's a fever from an infection, they don't necessarily have that much of an effect. But if it's fever from swelling or inflammation, sometimes they will offer a benefit. So the NSAIDs, their mechanism is somatic and visceral pain. So they are good for that superficial muscle or skin pain, but also for bone pain and deep organ pain. So they're used in a wide variety. Once they get it, now onset of action, I'm not usually having you, I do want you to know for the opioids how long they last. I gave you that yesterday in lecture. But these, they can kick in fairly quickly, and their duration of effect obviously will vary. But most of the time, the NSAIDs that we use can be given once a day or twice a day. And that's important when you talk to the vet, because, timing is keeping blood levels up, and it's different dosing if you're going to give it once a day, or it's, a different mg per kg dose. So, and a note that you always want to tell clients, a lot of times clients will see once a day and say, oh, why don't I break it in half and give one in the morning and one at night? You have to let clients know, if you're giving it once a day, there's a reason. That dose is formulated, and that dose, the way that it's distributed in the body, you don't want to alter that dosing. So if it's once a day, make sure clients know that you really don't want to split it up. If the client wants to do something twice a day, you can change the dosage and potentially do twice a day, but it's up to the doctor. So the analgesic and anti-inflammatories, certain ones are going to be stronger than others. But what this does is inhibits prostaglandin synthesis. Now, prostaglandin, and synthesis is creation of. Prostaglandins, if you remember, are tissue hormones, and they live in the tissues of the GI tract and the kidney, in the blood vessels. But basically, they moderate inflammation. When there's injury from surgery, and hopefully you remember this from pharmacology, but they basically begin that inflammation. Now, some inflammation is needed for healing, but then inflammation will also cause pain. So these are kind of going to inhibit inflammation. And the big thing that I want you to know is they have to be metabolized in the liver. They are eliminated by the kidneys and in the GI tract. So it is very important that we know their liver and kidney function before we prescribe these drugs. Because if they have elevated liver enzymes, elevated kidney enzymes, we may use a different medication. And these can cause issues with the liver and kidney. So it's very important, if they're going to go on these drugs, to get that blood work done. So what we're kind of looking at is they prevent the production of the beneficial, that's kind of like, it's a double-edged sword. We're preventing the production of the prostaglandins that cause the pain. We're also preventing some good prostaglandins. So when we use them, we're kind of looking for, like, I went to a lecture not long ago at like IVMA, and someone made a comment, the perfect NSAID does not exist. They're always trying to modify them. And what we're trying to do is, if you remember, there's COX-1 enzymes and COX-2 enzymes. Now, COX-1, they want to, inhibit COX-2, but they don't want to necessarily, stop COX-1. So if you remember from pharmacology, some NSAIDs are COX-2 selective, that they don't minimize, the COX-1, but they minimize the COX-2. So it's basically like they're trying to be selective for which one they inhibit. Because again, you need a little inflammation for healing, but we don't want enough inflammation that it causes pain. Some of the side effects, and this is a very important slide because they do have some significant side effects. And the big number one, and it's very patient dependent, is we worry about stomach ulcers, vomiting, GI bleeding, lack of appetite. And I know that you guys have already seen on tests, I like to ask client education-based questions. What do you tell an owner when you send them home? Well, how does an owner know their dog has a stomach ulcer? You cannot see their stomach. The dog can't point at their stomach and say it hurts. So what would a dog show that we would be worried? Well, number one, obviously if they have vomiting, if they have diarrhea, if they have any melena, which, melena is that digested blood. Now, if you remember, frank, bright red blood in the stool comes from the lower GI tract, like the colon from colitis. If it's a black, tarry stool, then that bleeding is coming from the upper GI because that blood is being digested, and that's why it's darker. So that's coming from like the upper small intestine or the stomach. So that's the difference in where the blood is coming from, is the color of the stool. But some dogs will just stop eating, or they'll go to their food like they're hungry, and then they start to drool because the smell of their food makes them nauseous. So the GI ulcers and the hemorrhage, obviously that's a more advanced clinical sign, but if you've got drooling and appetence, we put this on our label. And I always told owners in the room, I'm like, if you notice any of this, call us and stop the medication, because we can switch medicines. We can put them on a different pain medication, maybe alter the dose. But if we see any GI side effects, some dogs, I don't know if, in your family or in my family, some people can take Advil. I've got a pretty good iron stomach. But I have a family member, it's like they can't even take 2 Advil and they just get sick to their stomach. So it's the same principle, that sometimes people can take meds and sometimes people are sensitive, and you can't always predict that. We do worry about renal toxicity, because that it has to be excreted or eliminated by the kidneys. It can cause an elevation in those enzymes. It can also impair platelet aggregation, because anytime we use an anti-inflammatory, it can make the platelets less sticky. So if we're worried about bleeding, a lot of times we won't use an NSAID in those patients if we're worried about extended bleeding times. And it can cause liver damage, because again, it has to be broken down by the liver. And anytime you're making the liver work, we can cause issues. You have to, if they're on drugs for heart disease or hypertension, there can be some interaction with those drugs, and the doctor would evaluate that. But one thing that I want you to know is you have to obtain lab work prior to starting. So our protocol, when I was at VCA, we used a lot of NSAIDs in cancer patients. And if they've never been on an NSAID before, our protocol is we would draw a chem panel, and we get, the BUN, creatinine, their ALT, their liver enzymes. And we would look at what they're starting, and we would prescribe them 2 weeks. Now, a lot of our cancer patients were on NSAIDs we wanted them to be on it for the duration of their illness. But the reason we didn't prescribe more than 2 weeks is because if they're going to have a problem with their liver and kidneys, we usually see it within 2 weeks. So we draw baseline blood work. And this is important because this is kind of the protocol. You draw baseline blood work. We would prescribe 2 weeks of Rimadyl, for example, and then we'd have them come back and have repeat lab work. And if everything was still the same, if there was no change in blood work over 2 weeks of medication, we could prescribe them up to 6 months. Sometimes we did 2 months, 3 months. But once a client takes medication home, they can't return it to the clinic. It's left the hospital. Technically, by law, you're not really supposed to take it back. And so and these medicines are expensive. A lot of these non-steroidals are not cheap. There are some generics available, but I don't want to send home 3 months of medicine, and then after 2 weeks, the dog's kidneys are trashed or their liver, and then this owner is stuck with medicine that they can't use. So normally, and a common thing is when you tell an owner, hey, we need you to come back in 2 weeks for blood work, what's an owner going to say? Well, you just did blood work. Why do you need me to repeat blood work? Well, you have to explain that we're checking to make sure nothing has changed. None of the, values have changed over that 2-week period. And again, we would give them, they could get up to 6 months of refills on that recheck blood work. And then we would recheck the blood work every 6 months. I've seen dogs that are on Rimadyl for 2 years for arthritis, and they're totally fine. They've taken it for 2 years, but those animals are coming in at least every 6 months to have blood work rechecked. If they're on these medicines long-term, now if we have a dog that's taking it, like you guys are going to be using them for spays and neuters, we'll send home like 3 days of Rimadyl. We're not talking like weeks and weeks, but when you're dealing with chronic pain, cancer, arthritis, those animals are going to be on them for a longer period of time. And so there needs to be some check-in with them, make sure that they're doing okay. So there's specific, and the other thing is, and I don't have this on here, you have to make sure they are not getting prednisone. You cannot use a steroid with a non-steroidal. I mean, that's the fastest way to cause a massive GI ulcers. And in extreme cases, GI ulcers can rupture, and then you have a peritonitis. So they can have severe consequences. And, you know, so first of all, you have to make sure they're not getting aspirin or prednisone, because a lot of times dogs come in with allergies that have been on pred for so long, and sometimes the owners just don't even think about it. It's like, if they're on prednisone and you need to put them on an NSAID, that we do what's called a 7-day washout, where we have to stop one medicine, wait 7 days for that medicine to clear, and then start the new medication. Or you have to put them on heavy stomach protectants like sucralfate and Pepcid and things like that. So there's specific rules, and you want to make sure that we ask and get a good history. And again, if they've been at your clinic, you probably have a record. But if you work ER or specialty, we get clients and we don't know their history. And a lot of clients think, especially on ER, they're like, can't you get access to my dog's records? Like from a completely different hospital. It's like our record system is not completely linked. I don't know why clients to just have this impression that at 2 a.m. we can magically pull up their records. So a lot of times in my line of work, I'm relying on the client to be able to give me the history of medications. I don't always have access to their information, but you always want to check. And I want you to, you know, these are some big rules with these medications. Also making sure they're hydrated. There's a note down here, because if they're dehydrated, you know, that's going to affect their platelets, platelet aggregation, their kidneys. So, you know, making sure they're well hydrated before we start these medications is also going to be key. Now, once we get past NSAIDs, you know, the drugs that I've just talked about, opioids, NSAIDs, are kind of like our big categories. Now, opioids, again, opioids aren't typically sent home. Most of the time they get the opioids in the hospital and then we send them home with an NSAID, except for like buprenorphine in cats, potentially butorphanol tablets, but most of the time opioids are for in-hospital use, or a fentanyl patch could be at home. And then they get sent home an NSAID. So we can use some of these other categories, and local anesthetics, which is the other PowerPoint. Those are usually used in the hospital. You can, you know, I'm not going to get into depth with this right now because we're going to talk about it in the next PowerPoint, but, you know, you can inject the site, you can splash them on the site. And the nice thing about local analgesics, or the local anesthetics, is they have their local action and low toxicity, because they're usually, when you use a local anesthetic, you are not putting it in the bloodstream. You are applying it to an area. Now, some of that does get absorbed in the blood, but when you give a local anesthetic, you're looking for local effects. So that low toxicity is key, and they kick in fairly quickly. Now, the problem is they don't last very long. I mean, an epidural can last up to 24 hours. Sometimes it's variable, but most of the local anesthetics, we're talking about an hour or two of pain relief during surgery or right immediately post-op. So they're not really getting the patient relief at home, but in the hospital, they are good. Now, if you give repeated local anesthetics, you can get some CNS and some cardiac toxicity. I will tell you, cats, you'll hear me in the next lecture, cats are extremely sensitive to local anesthetics like lidocaine and bupivacaine. So their dose, every patient has a maximum lidocaine dose. And usually when we're doing blocks, I always calculate their maximum lidocaine. And I know that if 2 mils, an average max dose in a cat is only 2 mils. So if you do multiple blocks, they can't get more than 2 mils total. So we have to keep track of, if we're doing ring blocks for declaws, that means the cat can only get 1 mil for each paw. So we can't, because again, even though you're giving these drugs, you're not giving them in a vessel, you're giving them in the tissues. The blood supply, that's how the drug is metabolized. It's going to get absorbed into the bloodstream. And as long as you don't go over that max dose, usually the patient is going to be fine and doesn't have any side effects from the local anesthetics. Now the alpha-2s, I've told you alpha-2 agonists, which is xylazine and dexmedetomidine, do have analgesic properties. Now in small animal, we usually use them as a pre-med. And they're only going to get you maybe an hour. You guys saw your radiology dogs. We're only really sedated for a max of about 45 minutes to an hour. So the analgesic effects are short-lived. And then remember, you do have the adverse. You can get some vomiting, you get bradycardia, you can get heart block whenever you use an alpha-2. Those are normal kind of side effects. But you can use them in low doses. There are people that are doing putting dexmedetomidine in a CRI, giving it as a very low dose CRI infusion. So people are really experimenting with different ways to use these drugs. You guys will probably just use them as a standard pre-med, but there's some other use. And it can be good via an epidural. It's not common in small animal. In large animal, alpha-2s are used quite a bit. They're used a lot more in large animal because in horses, you can get sedation, muscle relaxation. Now, xylazine is used more commonly in large animals. Detomidine and romifidine, I did not lecture when we talked about alpha-2s because they're specific to large animal. They are large animal alpha-2s. And detomidine is related to dexmedetomidine. I mean, they're in the same family. It's just a slightly different makeup than dexmedetomidine. So detomidine, that's not a typo. There's a drug called detomidine, and there's dexmedetomidine. So they're a little bit different. But the nice thing is, horses, sometimes you'll do things that are called standing. We're going to talk about horses is our next lecture after this, but there are standing procedures and the horse will become sedate. A lot of times when we do field anesthesia, if the doctor has to go out to the field, there's things that you can do with them standing. And it can give you some analgesia for that moment. Again, if you need long-term analgesia, they'll have to add other drugs. And they are reversible. So again, if you get into trouble, that's the nice thing about alpha-2s. Now, I've talked about ketamine, which when we've talked about ketamine, I've talked about it as an induction agent. Like when you do kitty magic, the ketamine part of that is your induction or your anesthetic agent. But it does have analgesia, and it can be added to a lot of these different protocols. The thing is, if you just gave a cat ketamine by itself, it does give some analgesia, but it's not as potent. But when you mix it with other agents, it's enhanced. So for example, I want you to know MLK is a morphine, lidocaine, ketamine CRI. Now, when we do an MLK CRI, the dose of morphine and ketamine are not like your pre-med or anesthetic doses. These are what are called sub-anesthetic dosing. So the dose in there it's much lower than what you would give if you were inducing anesthesia. So, you use a very low amount, it's diluted in a bag of fluids, and you drip it in. But I want to say almost all of our orthopedic surgeries at VCA and when I was up at Northwood all got put on an MLK. Every dog for surgery, we would kind of line up an assembly line and we would make MLK bags, because if they had 6 surgeries for the day, every dog is getting their own MLK CRI. And then that CRI runs during surgery, which helps lower your MAC because we're treating pain. And the lidocaine in this bag is going IV, because lidocaine can be a systemic, it kind of acts as a pain, it helps treat pain. But again, we're using under their maximum dose of lidocaine. So it's not going to reach their maximum levels. But it helps block NMDA receptors at the level of the spinal cord. So we're hoping to prevent that windup, which is that higher level of pain. So I just want you to know there's sub-anesthetic dosing. Now, whenever we use ketamine, I'm always aware of these common side effects. Now, again, these are sub-anesthetic doses. We don't expect to see a lot of these side effects, but ketamine is a cardiac stimulant. It does increase heart rate, so you could potentially get tachycardia, and it can sometimes cause hypertension. So I watch my blood pressure, watch my heart rate. If I have a patient that has a history of seizures, now you can take the ketamine out of that CRI. You can do a morphine CRI by itself. You could do morphine lidocaine. So if you had a patient that had a history of seizures, maybe just drop out the ketamine. So you can still treat that animal, making some adjustments. Now, post-operative delirium, again, you shouldn't really see that because we're using such low dose of ketamine, but it is a hallucinogenic. So you just want to watch them. Normally these dogs sleep really well after surgery. They're nice and snoozy. And kind of the plan is if they come out of surgery, say at 2 p.m., they're on it all night. And then somewhere around 2 a.m., 4 a.m., usually the ICU staff starts turning the drip down. So then what we're doing is we're starting to wean them off. And then hopefully at 6 a.m., when we feed them in the morning, if they eat, then we're going to transfer them to their oral Rimadyl or their Tramadol or whatever, and then we'll take them off the CRI. So usually we start to wean unless they're extremely painful, but eventually our goal is to transfer them to an oral medication protocol and get them off of the CRI. Now, a drug that I just mentioned that's commonly used nowadays is Tramadol. It's related to the opioids. It's not it's a non-opiate, but it does have activity at the mu receptor. So it does help, it helps at the opioid receptors, and it helps treat pain. It's not as potent as the opioids. So, it's not going to be as strong, but it's used a lot post-op. But this is an oral tablet. So once they begin eating, like I said, the next day, we'll usually put them on the Tramadol. And the nice thing is it can be sent home. It used to not be controlled. It is now, it says a Schedule 4. It may have been booped up. It was it used to be a Schedule 5. So it had to, at our hospital, it's locked up. We have to count it before we send it home. So it has to be tracked. And you do worry. Let me mention bogus refills. So we had an oncology patient, and we have people that come from very far to come see us. And this dog had been pretty bad cancer. The owner elected not to do chemo and radiation. So we sent home Rimadyl and Tramadol, and we hadn't heard from the owner. And I want to say it was maybe 4 or 5 months later, we get a call out of the blue that she would like a refill. She wanted us to call in 2 or 3 months worth of Tramadol. And we're kind of like, not to be rude, we're like, your dog is still alive? Because based on the cancer and the patient's condition when we saw them, and we hadn't heard from them for quite a while, we're like, okay, this is weird. And, so my boss was like, well, if she wants to bring the dog back in for a recheck, we can recheck the dog and we can prescribe more tramadol. And she's like, well, why can't you just call it in and I can just pick it up? And we're like, well, I mean, normally when it's been that many months and we haven't seen your dog, and also we kind of need proof that your dog is alive. And then she kind of was like, oh, fine, I'll just go to my vet. Well, when we called her local vet, they had tried to call there, but refused to bring the dog in, and had tried to call another clinic and had refused to bring the dog in. So we think, because tramadol is used in people, so we do worry about people taking their dog's tramadol. Now, we used to send home months and months of tramadol. Now, we'll send home like a very short course, 3 or 4 weeks of tramadol, and they have to come in if they want another refill. So you can get bogus refill phone calls for this drug, and you have to be cautious. You would pray that someone wouldn't be taking their dog's medication, but I don't put anything past a lot of people. I need you to put something in your notes. The only thing I tell owners with tramadol is they need to watch for sedation, well, ataxia and constipation. Sedation, ataxia, and constipation. And tramadol can be given up to 4 times a day, sometimes every twice a day. Usually we give owners some flexibility. We used to say give it every 8 to 12 hours as needed for pain. But if you have an animal that's extremely painful, some dosing, now it depends on, the doctor sometimes will adjust the dose if we want to do 4 times a day. But I know there were some cases of some cancer pain where we had upped it to 4 times a day. But I also, whenever you send a medicine home, how does the owner know if the dog's having a problem? This does not cause GI ulcers. You need decent liver kidney function, but it doesn't affect the liver and kidney like the NSAIDs do. So they need to be cautious of that. Sometimes tranquilizers, I will say, these do not have analgesic properties. Some dogs are sent home ACE. Some dogs are put on trazodone, things like that, and that they can help calm the patient, but they're not doing anything to treat the pain. So sometimes if we have a patient that's very anxious, we might add a tranquilizer into the pain protocol. But I always tell the owner, whenever I send an owner home, I'm like, this is for swelling, this is for pain, this is for sedation. I make sure they know what each drug's purpose is. Why are we sending that drug home? And if we're sending home acepromazine or trazodone or something like that, it's, we're kind of adding it in to calm them down, and to help enhance the analgesics. I do want to mention gabapentin, which is being used a lot. It's technically an anticonvulsant, so it can be used in seizure protocols, but it's good for neuropathic pain. And neuropathic pain, now this can literally mean an injury to the spinal cord, an injury to the nerves. But gabapentin helps calm nerves that are overfiring. So sometimes gabapentin, we usually add gabapentin if there's a higher level of pain. Because again, so a lot of dogs are very common, like severe surgery patients would go home with tramadol, Rimadyl, gabapentin. And again, I've told you, sometimes owners are like, are you trying to drug my dog? I don't want to give my dog this many medications. But you need to explain we're treating pain at different pathways. This doesn't do anything for swelling. And it's not an opioid, but it's going to calm those nerves. And especially if you have a dog that has chronic pain and maybe they've gotten used to their NSAID or the NSAID isn't working anymore. The only thing I worry about, some keys here, is that it can cause drowsiness or sedation. The gabapentin shouldn't make your dog sleep through a meal. It shouldn't make you unable to get your dog outside. So that's what I told owners. If they're just a bump on a log, you can't get them outdoors, you can't get them to eat, There's, you know, they may sleep a little bit more, which is not terrible, but we need them to also be an interactive pet. We don't want them completely worked out. That's not the goal. And the nice thing is gabapentin has flexibility of dosing, you know, once a day, twice a day, up to 4 times a day, depending on the dose. Now, the other thing to worry about with gabapentin, this is also, and I know I'm trying to give you guys tips because I know you're almost out there. And if you're already some of you are working somewhere, you have to tell clients, this isn't give one pill and my dog is like jumping through hoops. Woohoo! Gabapentin has to build up in the system. So usually I tell clients, you have to give this for a couple days because clients want instant gratification. And gabapentin has to reach plasma levels and has to build up, and you have to give it consistently. So, you know, every dog has good days and bad days. And sometimes if a dog is feeling really good, they're like, oh, you don't need your medicine today. And they don't give it for a couple days. And then your dog has a bad day, and then they want to give it. Gabapentin is a drug that's going to do better if they give it on a consistent interval. And it's going to take, it may take a couple days to build up. So just make sure they're aware, this is not a drug that's a quick fix. This is not a drug that instant gratification, you have to give it for a couple days. Now, it is a capsule. In cats, there is a liquid form that you can buy, but you have to be careful. If you order the liquid form from the pharmacy, or like, I mean, if you order it from like a distributor, the human liquid form of gabapentin contains xylitol, and xylitol is toxic to dogs and cats. It's an artificial sweetener, if you've not talked about xylitol yet. That's why we don't like animals to get sugar-free candy or sugar-free gum, because it can put them into liver failure, and it can drop their blood sugar. So you have to be very cautious with xylitol. You know, we had to induce vomiting in a little Westie that ate a pack of sugar-free gum. I mean, it was the best vomiting experience because it smelled like spearmint, which was kind of funny. I was like, wow, it doesn't smell awful like most vomit. But the dog ate the entire pack of Trident sugar-free gum with xylitol. And in a Westie, you know, that's going to be a higher toxic dose. You can use gabapentin in cats, but I will tell you, you don't give it as often in cats. They're a little more sensitive to it. Sometimes we give it only once a day or every other day in cats. There's different dosing in cats, and we usually get it compounded at a compounding pharmacy. Like there's one in Nora, there's one in Greenleaf, there's one in Noblesville. Greenleaf is in Geist. So there's a few different compounding pharmacies. So again, you don't want to get the pre-prepared. And again, a capsule, you don't want to mess with trying to open a capsule and give half. You're just asking for trouble. It's better to just, we would have the owner go to the compounding pharmacy and pick it up on their way home. I'm not going to talk about amantadine. That's a newer drug. If they're not being responsive to tramadol and gabapentin, it's another level of a pain medication. But I want to mention real quick about corticosteroids is that the corticosteroids are your prednisone, your dexamethasone, and they decrease the prostaglandins like NSAIDs, except they're more powerful. I mean, they have very strong anti-inflammatory properties, and they absolutely cannot be given with NSAIDs. Everybody needs to know that, and you can expect that that's going to be a question. I'm literally telling you this right now. You cannot give them together. So you need to know one or the other, and a 7-day break in between if you're switching medications. But they are ulcerogenic. That's some of the side effects. And long-term, they can be immunosuppressive and cause that hyperadrenocorticism, which is Cushing's disease. So when they're on these long-term, they have some pretty strong side effects. Now, because they are strong anti-inflammatories, they do treat pain, especially if there's stubborn swelling. But again, most of the time, Dogs on pred, we don't normally send pred home for swelling for pain relief. We'd much rather use an NSAID. We sometimes had bad cancers that caused a lot of swelling, and sometimes that dog didn't have a whole lot of time. We'd switch them to prednisone off of Rimadyl in extreme cases. But I don't want you guys to know this isn't a common category used to treat pain. But if there is a massive amount of inflammation, sometimes, you know, these are obviously more powerful, but you need to know what corticosteroids drugs are. Prednisone, prednisolone, dexamethasone, zone. A little tip, especially when you get into VTNE, is a lot of your drug categories have that similar part of their name, so you know they kind of belong to that group of drugs or that group of drugs. And again, I've said this before, multimodal therapy is our goal. That's what you're explaining to the owner. The reason we're sending you home GABA, Rimadyl, Tramadol is we're treating pain at different modes, different pathways. Therefore, we create a pain protocol. We're not trying to make your dog a druggie. You know, we don't really deal with that in dogs, which is nice. So making sure that owners are knowing why we're sending home more than one, you know, medication. So example now, acetaminophen and codeine, that is a pain medication that can be prescribed from the pharmacy. It's not used very much. But fentanyl and meloxicam, if you use a fentanyl patch and then you give them meloxicam until the fentanyl patch kicks in, or morphine and Rimadyl, like you guys are going to use butorphanol and Rimadyl in your surgery patients. So we're giving two different kinds of pain medications. And then I told you the MLK CRI. And most of the stuff I've talked about is you're sending them home. So, you know, now we do not use oral morphine. There is an oral morphine, but we do not currently use them. I mean, we just would not want to mess with clients abusing that. So we don't use oral morphine. We do send home fentanyl patches, Tramadol, NSAIDs, not really Tylenol with codeine, even though it says that, that is a form not used quite a bit. But again, things that we can do is keep them quiet. You know, I know we got to go here in a few minutes. Let me just mention that I've been fooled sometimes in the ICU, and I have a dog that's crying and crying, and I've been guilty of this, and I'm like, oh, they must hurt from surgery. And then someone takes them outside, and they urinate for like a half an hour, like they had a huge bladder, and then they come in and go to sleep. So you never want to neglect whining, shifting of positions, and crying, is maybe the dog has to go to the bathroom. And again, I found myself guilty of sometimes overlooking that, but sometimes they are just, have they gone out to the bathroom? Do they have ability? Because there's a lot of dogs, they will not urinate in their run or their cage. They're just trained like, I go to the bathroom outside. So you don't want to assume that if a dog's got to go, they're just going to go. I mean, I've had dogs that have held it for quite a while in their run, and then you bring them in and they pee, or you know, they go outside and they pee, and then they go to sleep. So you know, comforting, getting them good bedding, getting them in a comfortable position. If they're laying wonky, maybe that's why they're painful. Try to, you know, shift them so they're also not putting all their weight on one side. And there is, you know, we use cold and heat therapy at VCA. We have a rehab department at VCA, which, you know, works with a lot of the post-op patients, and they'll come into the ICU and do massage or apply cold packs post-op. There is, you know, laser therapy. A lot of clinics have a medical therapy laser, so you don't want to ignore that. Okay. That's all I have for today. Do you have any questions?